So, good morning. We were having a little bit of a bandwidth problem a minute ago. It looks like it's clearing up. Today, we're going to be talking about the 3 COVID vaccines that are out there right now and being set up for emergency approval or for approval. Well, you can debate the whole term about emergency. Let's just put that aside and let's talk about the 3 vaccines, what we know so far and what we need to know. I try to stay out of political comments, but I cannot help but make this one comment as we get started. I saw a headline today. It was talking about, I believe they were saying 35,000 people have or will die during the time that FDA is looking at these vaccines. I've spent my time testifying for the FDA, and I can't help but reiterate that. I think the FDA does tend to move a little bit slow. Now, I'm not saying that we shouldn't be careful with this. I am saying that there are probably ways to move a little bit faster in that space. And I'll just leave that for now. We're going to go first into, again, as we usually do, a brief word from our sponsor, who's us, to talk about the services that we have available for you if you want to figure out, okay, you know what? I'd like to know what kind of risk I might have for heart attack, for stroke, for increased susceptibility to COVID-19 if I get coronavirus infection. And let's go through that real quick. And then we'll have the program as usual, and then we'll have Q&A. Previous topics we've covered, stress tests, cardiac caths, stents, the unnecessary triad. You know, I'm beginning to feel very successful in pushing that down. I didn't do that. I'm not that that megalomaniac to think that I created that huge decrease that's happening there. It's been a combination of coronavirus and social distancing. And again, just the quick comment that grocery stores remain open, same volume, continue to do work, yet the stress tests, caths, and stents have plummeted. It's not just because of coronavirus. There's also been a series of good science articles coming out showing that's really not the best way to predict a heart attack or stroke. There are better ways. We've got a book coming up about it. We'll talk about that in just a minute. One of our more popular videos recently has been a very simple video about cardiovascular inflammation is the cause of heart attack and stroke, not LDL. And again, very exciting to see the receptivity to that. And that's not just among routine channel viewers. It's expanding the audience quite a bit. More information on stress tests, a couple of discussions about dentists and why dentists should be involved in prediabetes care. That sounds really weird, but just one quick hint. If you've ever had bleeding in the gums when you go to the dentist, be afraid, be very afraid, and be afraid regarding prediabetes. The dentists usually won't tell you that, and that is a problem. So let's talk very quickly about a couple of other things. If you're curious, if you're interested, if you have a burning desire to know, do I have risk that my doctor hasn't talked about? My doctor continues to talk about LDL. I think there may be other things. You're absolutely right. And by far and away, the most common other thing is undiagnosed prediabetes. The CDC used to think it was 80 million American adults in the 60s and above. 1/3. Now they know that was way, way low. JAMA articles, UCLA have come out showing that the prevalence of prediabetes or diabetes is 50%. It's over 1 in 2. So you got to ask yourself, are you feeling lucky? Unfortunately, researchers at Hopkins and other places have shown the typical American primary care doctor does not know about this. They don't know how to diagnose it, and they don't know what to do for it. So again, the Got Sugar webinar is a great way to just say, you know what, I want to keep seeing my primary care doc, but I also want to make sure that I don't have a prediabetes problem that just has not been diagnosed. That's a great way to do that. As you see, we've got some Christmas specials, holiday specials making that available to you. Similar types of things. One of the most common reasons for coming to see us as a patient is somebody saying, you know what, doc, I got a calcium score and it was positive. And first of all, my doc didn't know to order that. I had to order it myself. And secondly, my doc really doesn't know how to interpret it. Again, come to see us. We also have some information on a supplements webinar that we can provide. We also have a new way of getting services. A lot of people have said, you know what, doc, you're just so dang expensive. And here's the thing, when you compare paying out of pocket, we don't take insurance for a whole bunch of reasons we can talk about if you want in the Q&A. But when you're comparing a non-insurance type of a service to insured, there are a couple of things that happen. The non-insurance program looks a lot more expensive, as we've talked about. With the insurance program, you usually get 7 minutes and a couple of scripts and thank you much and goodbye. And you don't get, as we said, a focus on the true drivers of heart attack and stroke. So again, the subscriptions are becoming more and more popular. If you just want to do a quick rifle shot, you're curious, you want to spend a couple of hours to learn more about plaque or insulin resistance, prediabetes, or cardiovascular inflammation. If you want to learn more than 98% of the doctors out there, you can get that for 20 or 30 bucks. Just get one of the courses online. I mentioned the book. It's coming out. It's been with the publisher for about 2.5 months now. The goal was to get it for them to keep it at 1 month. I continue to see delays in that space too. You know what? It's always hurry up and wait, isn't it? So the website, again, if you hear a lot of folks that watch YouTube are by definition verbal processors. We cover a lot of stuff, a lot of detail that it's really difficult to pick up verbally. We've gotten a lot of feedback about that. One of the things we've done to try to make this information much more available on a free basis is just to get it into writing and to get it on our website. We've done a lot of work on that. The website has gone from basically a brochure website at like 300 visits per month to way more than that number of visits per day, 400 to 700 visits per day. So it's very popular. There's a reason for that. We're getting all of our information into the website in blog form. Some of the blogs are very, very high quality. Other blogs have the content, but they don't have that blog pizzazz with the all the images and stuff like that. So stop by and take a look if you have an interest in the content that we provide. A lot of people prefer to go with podcasts, so we're doing that as well. Sam and Aspen and the guys started taking the content that we have and getting it, making that available in a podcast format. We're getting more and more downloads each week. So we're going to talk about the COVID vaccines, what we need to know. Soon as Aspen gives us the, I think the water ball. So if there's any content channel, whether it's the Washington Post, New York Times, or just little old us, One thing I think we can all guarantee is that we're going to make, there will be errors. When we find them, please fact check us, please point them out. I remember I was talking with, I still have a very active patient caseload, and I was talking with a patient just last week, and I think I told him it was the Oxford vaccine that had been rolled out in the UK, just linking Oxford in the UK. I don't think that was right. We'll cover that today. Now, there are three vaccine candidates: Pfizer and BioNTech, ModeRNA or ModeRNA, depending on how you pronounce it, how you want to pronounce it. And I've heard both. And the third one is University of Oxford and AstraZeneca. The first two are messenger RNA, and the third is a different type. And again, we've got a little bit of detail on this. We will provide more of that detail, again, in writing in the blog when we are able to get that through the process. But let's just talk about that for a minute now. The messenger RNA technology is the first time we've ever done this. We meaning human beings. It's a new mechanism. It's being used for the Pfizer and ModeRNA vaccines. The scientists were able to start developing messenger RNA vaccines using the viral genome, which was shared online as a template. You remember when it was still in China, they were able to get some the genome out there, put it online, and so from that moment, Pfizer and ModeRNA were able to start saying, okay, we're going to use that that genetic code to make a vaccine. Messenger RNA vaccine also does not require time-consuming steps, such as growing ingredients in chicken eggs. In the old version, you have rooms full of thousands of chicken eggs. Don't have that anymore, at least for this process. Pfizer and ModeRNA are projected to provide 40 million doses, which is enough for 20 million people. Remember, it's a 2-dose process by the end of this year, just a couple of weeks. The Oxford vaccine uses a harmless cold-causing virus, a virus that causes a cough, to deliver the genetic code for the spike protein. So in all three of these, the genetic code for the spike protein is being used, which makes all kinds of sense. If you're going to develop a vaccine to a virus, you want to develop, and you want the human body to develop antibodies and T cells and memory cells, other immune cells to the line the coding of the virus itself. The coding of the virus for coronavirus is what we call this spike protein. That's the first part that your body will see if you get infected. Some of this came from the Washington Post, great article, what you need to know about the Pfizer, ModeRNA, and AstraZeneca vaccines. And again, they've got some great images in there. We're going to produce as much of that content as we can in writing on the website. And you can also find it at the Washington Post article that we've referenced. The UK is the first Western country to start mass vaccination. Last week, British regulators authorized the use of Pfizer vaccine. This picture on the right is the first non-clinical trial patient to get the vaccines. We'll show a video of that at the end. In the US, FDA regulators will review the effectiveness, safety, and manufacturing of each vaccine. An FDA advisory committee will vote. The FDA may authorize one or more vaccines in mid to late December. CDC advisory committee will then discuss prioritizing the vaccines for high-risk groups. And a lot of those, there's a lot of articles out already which help delineate the sequence of risk, starting with the first responders and the folks that are highly susceptible. What is FDA's emergency approval? The FDA can issue an EUA, emergency use authorization, to quickly get medical products publicly during health emergencies. The FDA has already issued EUAs for coronavirus testing and a few treatments. It's only authorized one vaccine ever this way, and that was against anthrax in 2005. How will the vaccines be shipped? Well, the Pfizer vaccine must be kept at negative 70 degrees centigrade. Unless most of you know this immediately, that's really cold. It's a lot colder than your kitchen refrigerator. These are what, $50,000 freezers that are required for this kind of storage. Once it's thawed, the undiluted vial can be kept in a refrigerator for only 5 days. A diluted vial can be kept for only 6 hours before it must be discarded. The ModeRNA vaccine is stored frozen at negative 20 degrees centigrade, but it can be kept for a month at refrigerator temperatures. This makes it easier to distribute to pharmacies in rural areas without specialized freezers. The Oxford vaccine, you remember, is one of the older methods, not the new messenger RNA. So it can be stored at refrigerator temperatures for up to 6 months. That's an advantage. It makes it far easier to distribute and administer it throughout the world. What percentage of a population has to be vaccinated before herd immunity is reached? That really depends. One of the things that it depends on is, how do you define herd immunity? It's estimated to be around 70%, either through a vaccine or natural transmission. So if you look at this graph on the lower right-hand side, you see what happens in terms of active new infections and the number of people that are no longer susceptible because they've already either had the vaccine or had the infection. You get up to about 70%, and the active infection transmission down here in the red begins to drop. But as you see, it still continues. It goes back to that whole concept of R0, the reproducing ability of this virus. As we discussed early on, this virus is very contagious. It's, like measles is very contagious. The more contagious the virus, the higher the amount of herd immunity is required. This image that Chris has for us up in the upper right-hand corner is images that we used in terms of helping explain herd immunity. Now, are the vaccines safe? That's going to be a big issue. The full safety data have not been made available yet. They are actually in the hands of the FDA committee members, and that will be made public I think on the 15th during that meeting. No serious safety concerns have been reported in either trial. Intensive safety monitoring will continue after the vaccines begin to be used. That's called post-market surveillance, safety surveillance. Now, back to that sequence. Who gets it first? Well, it depends on the job, the age, and the health and susceptibility. A framework was devised by an advisory committee at the CDC. Most likely to be first would be healthcare workers working with this disease. I'm a healthcare worker, but I'm staying at home all day, every day, working out of my home. So I'm not going to be one of those first top priority healthcare workers. First responders, residents of long-term care facilities. That's actually one of the areas where I've heard a lot of criticism already, that you don't need it so much for the residents of the long-term care facilities as you need it for the workers at the long-term care facilities. I don't really have a comment. I understand the argument about that, but again, let me get back on script before we go down that bunny hole. People with essential jobs, such as teachers and food workers. Our son works at a grocery store. He has continued to work because he's a food worker. Those who are at higher risk due to age are going to be at higher priority than those with underlying conditions. Healthy younger adults who don't have medical conditions or high-risk jobs are likely to be at the end of the line. But still, even though at the end of the line, right now, that's estimated to be April or May, according to Tony Fauci. So As you note, and I'll have to say this too, I can't help but making a couple of jabs every now and then. In the beginning of this, Tony Fauci was saying it's going to be 2 years minimum before we get there. Now he's acknowledging we're likely to have this available for the last group in line in about a year, just a little over a year since the disease was discovered. So remarkable. The term warp speed is very applicable here. By June, 100% of Americans that want the vaccine should be able to get it, according to Lieutenant General Paul Ostrowski, Director of Supply, Production, and Distribution for Operation Warp Speed. He told to CNN. Children may get last access. Pfizer's the first and only company to expand its trial to people 12 years old and under. One shot is given. Let me go back and rephrase that. Here's a couple of questions. Once the shot is given, is the person immediately protected? This is a 2-dose vaccine process. It takes around 2 weeks for vaccine to kick in. Pfizer's booster shot will be given 3 weeks after the first one. ModeRNA's or ModeRNA's second dose is given 4 weeks afterwards. The Oxford vaccine also requires 2 doses. The trial found it was far more effective when the first dose was half the typical dose and the second was given a month later. That is, as you know, most people know, that's not uncommon for a lot of vaccines. And typically what you'll see with other vaccines is 60 to 80% uptake after the first, and then much better uptake after the second dose. Do not take that to the bank. That's got nothing to do with these. There's no data about these available at this point. Just remember, these are all 2-dose vaccines, and I'm sure that information will come out as you start getting into a mass vaccination program. There's going to be a lot more available. There are going to be a lot of cases which come up where people only got 1 dose, and we begin to understand a little bit more of the efficacy at that level. It's a 2-dose vaccine. Should a previously infected person need to be vaccinated? This did not exclude people who were already infected. Until the CDC committee evaluates the full data, the agency won't make recommendations on this matter. Again, I can't help but go off script on some of these things. Excuse me. My guess is that they are probably going to recommend that even people that have had it get this vaccine. And the reason is there's a lot of evidence that the vaccines are better at creating longer-term immunity than the infection itself. They don't create as much of the immune storm where the immune system is tripping over itself. So there's a lot of reason to suspect that they're going to say that. Again, that's not policy yet. That's my digression and my personal opinion. Well, people still need to socially distance. Yes, the vaccines are promising, but they're not a silver bullet. They're not an excuse for people to let their guard down. The vaccine doses are still limited, and it'll take time to get enough vaccine doses out there to create the levels of herd immunity that we'd like to see. Will people have a choice on which vaccine to take? You hear a lot of that conversation, or at least you heard a lot of that a few weeks ago. But once you begin to see what's going on, you begin to realize, you know what? Supplies are going to be very short initially. So your options are not going to be you're not going to have 3 options. You're probably going to have 1 option for a while. The vaccines have different storage and handling requirements. So most places are going to have probably 1 vaccine on hand. How will a person know which vaccine will be best for him or her? That's starting to get a little bit beyond where the evidence would take us right now. The FDA will first authorize each vaccine based on safety and efficacy. A CDC advisory committee will then subsequently make recommendations like whether 1 vaccine may be preferable for a certain group or another. What will happen if you don't get vaccinated? Well, if you don't get vaccinated, there are other vaccines that are being worked on. In fact, they're gosh, what? Less than a year ago, there were over 100 vaccines that were in some stage of development. I don't think we're going to end up with 100 and something vaccines. Probably, I don't know, maybe half a dozen or so. In most vaccine markets, you end up with more than one vaccine available. And I suspect that will happen here as well. Later generation vaccines, like I said, are in development. So, Gilbert, if you would, show us this 1-minute video of the vaccination of the first non-clinical trial vaccine patient.
Relax your arm for me. Still. All done. All done. All done. All right. I'm not supposed to show any.
So there you have it. We're officially off to the races in terms of making that those vaccines available. I will just make a couple of comments about the politicization or people's reactions to vaccines. There's a lot of vaccine haters out there. In fact, I have a personal interest in vaccines based on my earlier public health work. So I started getting involved in presenting a lot of information on the vaccines when they first started development about 6-8 months ago. We got piled on. A lot of people, vaccine haters, just started piling on and using this as an opportunity to politicize and state their general comments about vaccines in general and the politics behind them. Having said all of that, well, let me just make one other comment. So we slowed down dramatically on presenting vaccine-related content. As we're getting closer, obviously, we're going ahead and putting some of this information out there. And I think I mentioned last week that we have what I have called a vaccine hater on with us today. I see him smiling. Guys, you can go ahead and put James on the camera as well. James, when I've called him a vaccine hater, he said, "Now wait a minute, Ford. There's a whole world, a whole spectrum of folks who are maybe somewhat hesitant about vaccines and then vaccine haters. And so you need to be very careful how you label folks." James, you want to step in and defend yourself real quick? And guys, hold on just a second. We've got James's volume off. Can you make sure that we get it on there?
I think they've got it now.
Okay, great.
Great presentation so far, Ford. Thank you very much. Great topic, great information. Yeah, I know, tongue-in-cheek, you joke. A good description would be, I'm vaccine concerned. Reading the questions as we'll be going over them, I think you may be in the minority when you start reading these questions, that there are a lot of concerns. Now, obviously, I am very pro-science, pro-medicine, and I can roll up my sleeve and show you where I had my vaccinations as a child, and my children appropriately are vaccinated. So just so that the audience doesn't some later pull this up and play it in some future time, not understanding. But there are some great concerns. I'm excited to get through some of these questions that people are raising. It's probably the most misunderstood and challenged medical event obviously in our lifetimes. And this is going to create a lot of great content. So I suspect we'll visit this over and over again and start preparing and delivering to the audience pro and con information as it becomes available. I know behind the scenes we have great conversations about the concerns that people raise. And so I'm excited about this conversation. This is a great topic.
Me too. And at the end of the day, the reality, I don't think anybody can argue with the reality. And the reality is a medical vaccine is sort of like a car or a train or an airplane. There's some things that it can do to really improve your life if it works. Right. If it doesn't, things can go very bad very quickly. So that's what creates some of the debate that I think you're looking forward to. Right. And I don't know how much of this is going to be debate. If you're really looking for mudslinging, dust up, this may not be the one to attend. But we are going to get into this topic and talk a little bit more about it. My BJ, so let's go to some questions. Unless you had other content you wanted to cover first, James.
Nope. I have a list of questions that we've discussed to bring up, but most of those questions that we have prepared for are already filling the question and answers, or at least in the concern form. So
right.
I'll go through those. And again, my role is to challenge and to ask questions. And some of my questions will seem rather ridiculous to the audience, but I know sometimes I may already feel differently than the way that I'm presenting it, because I want you to really hit some of these questions and ask in a way that others may fairly ask. And I think one of the things that's important to emphasize is you have a strong opinion about these things, but behind the scenes, I know that you're very open to any evidence in any field of medicine. If someone wants to bring some science, I know you spend a great deal of time reviewing, sometimes even the ridiculous, because there are times in which there is discoveries that come from, how many people have been ridiculed that later we find out they were completely right in science and medicine in all fields. So I know you're open to these questions and are excited about people challenging you. So fill up we'll read over these. If someone has some concerns, wants to bring them up, attach something, we're tracking it as we go.
And just a brief comment, for those of you who are wondering about James's background. No, James is not a physician. James actually founded and ran a human genetics lab and a value-based healthcare network and developed a Medicare Advantage healthcare network, and is one of the. He's now working with us on the channel in terms of helping us spread this message. He's one of the most well-informed non-physicians in this space that I know. So what we'll do, James, until we, you and I can talk about it later, we can change, but right now I'm comfortable with hitting the questions and showing them on the screen. I'll plan on doing that. And then we'll divvy up who responds. My BJJ, Brazilian Jiu-Jitsu, good morning from Temecula. Good morning to you, BJJ. Good morning to you as well, Bart. Thank you so much for the super chat. For those of you, Gilbert, if you could just show very quickly up on the screen how to do a super chat if somebody would like to. Super chats. What do you call that other type of donation? Patreon. Patreon, PayPal, all of those are, of course, welcome. It helps us, again, the vast majority of our income at this point for this channel still comes from me seeing patients that want to be seen in the space that we're talking about. So I just, instead of taking that money, I just pour it back into the channel. We more than welcome those of you who want to help move this this message faster and to more people. Well, we're getting a lot of comments, and one of the things that happens when you do that is this comments list starts blowing up. So if we miss yours, we're doing the best we can. Kathleen Reyes, good morning from Athens, Georgia. Good morning, Kathleen. I don't think I've seen that name before. Thank you and for joining us, and welcome. My BJJ, sorry to hear that, Bart. Uh-oh, I missed something about, oh, I think it's a very cold and gray day in New Jersey. My BJJ's rubbing it in that in Temecula, California, he's wearing shorts and a t-shirt. I'm not wearing shorts and a t-shirt either. It's about 31 degrees here in Lexington, Kentucky. Bart Robinson, oh, I'm so jealous. Okay. Good afternoon from Brazil. Good afternoon to you, Maria. We've got a few Brazilian patients. Very, very smart group, very well informed, and doing some great work. Thank you for attending. Laura Rance, are they going to make vaccine mandatory? I don't see that in any immediate future. You get that question. A lot of people say, you know what, I'm not ready for that. And this may be an impingement on my civil rights. I have not heard any inkling anywhere of any representative even going there. I mean, the problem right now is getting enough vaccine for the people that want it. Any comments from you, James, on that?
No, I hear that a lot. That's a main concern. It won't be a concern because as you said, you couldn't make 300 million vials and have them ready in the next couple of years. You also get a significant, as I track people's comments, not here, but in a lot of other forums, there's a interesting crossover between there's a lot of people with a religious context to this, where they're saying this is the chip, this is the a certain
mark of the beast.
Mark of the beast. I mean, there's a lot of really deep-seated concern that we have to be mindful of, that is sincere and devout about this. But so far, there at least is still a lot of people in various governments around the world that I don't think they could pull that off. I don't think they can make it mandatory. Probably the biggest concern that I see that is a reality is, will they require it for children to go back to school? Right now, they're saying children get in the backside, which is a whole nother conversation of why are our schools out? If the children can wait to the last to be vaccinated, I think it's a legitimate conversation. Well, then why are they not in school? If we're not concerned because they don't have the ACE receptors that really uptake and infect a person significantly or seriously, then why are we out of school? That's a great conversation.
That's a great conversation. And those of you who were involved may be aware that we did a lot of consulting early on with with KPMG. I think it's public. That conversation is public. But James was involved with us on that. One of the things we started doing sort of midway into this lockdown or social distancing program was to start working with schools. What happened was that really went by the wayside, that consulting group. Again, we had docs, myself, some other docs who are currently active at Hopkins, some docs who are currently active at Harvard, UK, some recent, some folks that know what they're talking about. And again, that issue came up about schools. We started getting involved in terms of how to help the schools make that decision. And then very quickly, students started getting infections, outbreaks started happening in schools. And for the most part, most schools ended up shutting down again, as we all know. That consulting ended up just petering out. There are schools, for example, here in Kentucky who filed a class action suit. I think it was the Christian schools, and were able to remain open despite a governor's mandate to the opposite.
Do you want to comment some forward, the ones that are interested, about the development of the cell and the ACE2, I believe it is, receptor that is the piggyback for the virus, and why with young people it's less likely that we see the severity, and how that impacts, why that question is so important for parents with children who are concerned, and are we creating an undue fear in children and parents? Because my own children, they hear the audience, from other sources, creating real fear in 5, 6, 7-year-old children that you may get COVID. It's the COVID, by the way. It's not coronavirus. So you may get the COVID,
Right.
you'll get the virus. And we have to reassure them that that butt whooping you're probably going to get from me for misbehaving is a lot more dangerous in your near future than the COVID is. So do you want to comment on that? Not the behind whooping. That's
all right. So
humor.
You're going to get us banned on YouTube there, Jim.
I know that was humor.
No, you won't. So I'm not an expert in that area, but there's a few things that I do know. I mean, this was like the first few weeks of this pandemic, when all of the articles, all of the clinical articles, and most of them were coming up in the New England Journal, and almost all of them were coming out of China, because that was the only place that had significant experience at that point. I cannot remember the first big article about children's experience there. I can't remember if it was something like 1,300, 11 or 12, 1,300 kids, 5 and under, who'd had this problem. And I think it was 5 and under. It may have actually been 12 and under.
I think it was under teenage.
So out of that huge group, there were 3 deaths. You can't see my fingers. Here we go. 3 deaths. All 3 of those deaths, were due to cancer, kidney failure. They were problems that pre-existed the COVID, and they were the cause of the death, not the COVID. So you just were not seeing deaths among kids. Now, that's one data point. You move fast forward and move into the transmission to the rest of the world, and then you started getting these reports where it happened, and you start hearing people say, "Oh no, don't let them tell you that. Don't let them tell you that kids are completely safe. This child had a death, that child had a death." I've still not seen significant evidence that this is a major risk factor for young children, independent of other problems, like we mentioned early on. As James mentioned, there's some theories surrounding ACE receptors. For those of you who watch this channel, you may begin to make connections. One of the most popular and effective drugs for cardiovascular inflammation is given for blood pressure problems, and it's an ACE inhibitor. So you start making those connections. One of the early articles that came out that took us down a major bunny hole for many weeks was a theoretical article. It was raising this question: do ACE inhibitors increase our risk to COVID-19? At the end of the day, there were multiple studies which evaluated that, and at the end of the day, the answer appeared to be no. I personally am on an ACE inhibitor. I am not recommending people to get off of their ACE inhibitors if they're on one. I don't hear the uncertainty, the questions, the concerns surrounding that space anymore. I'm hesitant to go any further into the ACE category unless you have specific questions, James.
Nope, great.
It was a good point. As you see, and as you mentioned, and I mentioned earlier, there are a lot of people that feel very strongly that these vaccines are a problem. And there's more than one. And there's a lot of people that feel like all vaccines are a problem. So not sure what else to say about that. Burning questions. I'm more interested in the Johnson & Johnson Janssen vaccine. Only one shot and likely 100% protection from getting the virus. That's very interesting. I'm not personally familiar with the J&J vaccine at this point. I'm sure that if it comes up as you're describing, it will become, a lot of information is going to come out about that pretty quickly, or as soon as it's available. Fortunate Nanette, another watcher mentioned, I don't want to be forced to get the vaccine. Not sure what else to say. I don't see anybody, at least in this country, in America, the US, getting forced to take a COVID-19 vaccine anytime in the foreseeable future. My BJJ, I'm 5.5 months out from getting COVID. I gave convalescent plasma again yesterday. I'll be interested to see if my antibodies are still detectable. They test for them each time, and I should know today. Very interesting, BJJ. Thank you for that comment. And please let us know next week when you find out. Bart, I'll most likely get the vaccine eventually. And Doc, you'll be happy to know I'm getting my second Shingrix vaccine later today. 2 people I know recently contracted it. Very bad. You know, thank you for mentioning that, Bart. That gives me an opportunity to head down a bunny hole. So the bunny hole is this. Vaccine reactions. You know, a lot of people, if you do take a vaccine, Shingrix brought this up. I've rarely had any significant vaccine reactions, but I had a big one to Shingrix. My wife had an even worse one. And Shingrix is well known for having a lot of very serious, or not serious, very uncomfortable reactions, fever, flu symptoms, etc. Now, what do you do for that? Most people think, well, you take aspirin or an anti, Motrin, something like that, or something to decrease your fever. Here's the thing to know about that. That probably does decrease the effectiveness of the vaccine. There's a reason that the human body creates fever. The immune system needs it. It helps the immune system in terms of developing lasting memory of defenses mounted against a problem. So, I come from sort of a culture of just grit it out, bear the pain, no gain. And that's the information coming out about vaccines is beginning to indicate that that's very much appropriate for getting a vaccine as well. James, any comments on that? And guys, if you could just keep James's image up there, I think that would be easier.
Well, easier maybe for processing, but not easier for the audience. There's a question that we're going to come up in just a minute while you're on that segue of what's the difference between a vaccine and convalescent
serum,
right? So that may be a great time to address that, the difference between the natural response and the synthetic. So if you want to talk about that, I know that's coming up, and that's a great time to talk about that.
Okay. So a vaccine is where you get from one version or another, you get a bunch of as we talked about earlier, you get part of the protein or part of the virus itself. In this case, that spike protein that's so critical to hooking the virus to the cell membrane. Again, if you can develop an immune response to that hook, then you sort of neutralize, well, you don't sort of, you neutralize the virus's ability to infect cells. Now, as James is bringing up, and as evidently is coming up in a question in a minute, what BJJ mentioned that he's donating his own convalescent antibodies. So what he's doing, he's had the virus, he's been infected with it, his body has built antibodies to it. What they're doing is taking those antibodies, they are taking the other stuff out, and they're making those antibodies available to patients as they get sick. This is a very old technique. It's convalescent serum. In fact, before we had significant antibodies, penicillin became a big deal for strep throat and rheumatic fever. Prior to penicillin, we mostly used convalescent serum, exactly the way that they're doing right now with my BJJ serum for COVID-19. Now, there's been some questions about just how effective that is. I'll make a brief comment, current history kind of comment. I believe that the president, when he got COVID, got very early treatment with convalescent serum, as well as a couple of other things. So back to the point, there's been a lot of question about just how effective that is. Now, scientifically, that makes sense, and here's why. Especially with a virus like this, you got to ask the question, how much of it's just antibodies and how much of it is memory cells, other T cells? The immune system is an entire orchestra. It's just not one instrument. And you need to have every component of the orchestra to mount the very best defense. Understanding that analogy helps you also understand how it may very well turn out that the vaccine provides better lasting immunity than the infection itself.
Right. That's a question that comes up as well.
Okay.
A little bit. So good to hit both of those.
Angel Luis Fuentes, Pfizer and ModeRNA vaccines do not prevent contagion. At best, they reduce symptoms. So what herd immunity? None at all. Angel, I'm not exactly sure your logic on that comment. James, I'm not planning to respond unless you have comments, James.
I think it's just an opinion comment that's good. If Angel has more, a link he wants to send in to something for us to look at, we can respond to, be happy to do so.
Very good. Fernando, what's the difference between a vaccine and plasma antibodies for COVID? That's the comment I think you just mentioned, James. That's what we just spoke to. Bill H, no way I will take that vaccine. Vitamin D3 is my vaccine. I get it, understand. No comment. James?
There's a lot of evidence that there's undeniable evidence that the vitamin D levels are very defensive in this guy. I think those studies have come out, several of them, and I think it's indisputable that the higher the vitamin D level, the better you're able to mount a response. To the point you made, just because I have higher vitamin D levels doesn't mean I have other complications that may undo that. But certainly, we talked about this some last week, at least 5,000 international units of vitamin D is anyway good, healthy protocol to follow for your heart health. So I can't imagine anyone. I take it through the Restore V product. I take a couple of those a day, each in the morning and the evening, and that gets me a little over 5,000 international units with other things. So I think you absolutely ought to take it. Whether or not you're going to take the vaccine, you ought to certainly take vitamin D3.
Great point.
Brewer.
What's that, James?
According to my doctor, Dr. Brewer.
It's a great point. And to that point, obviously, I think Bill knows this as well. Vitamin D3 is not a vaccine. Vitamin D3 does act actually as a hormone. It's very important. It used to be a distant number 2 in terms of my armamentarium on the whole cardiovascular / prevention programs. Since COVID happened, it became a very distant, very far in the lead number 1 that I always make sure to ask people about. I think it's right now, by far the most important thing to make sure that you have a good level on. Batario 723, we know this vaccine has been rushed to the market. It is not safe and causes infertility. We know that mRNA vaccines are not tested and other vaccines have not been tested. This is all a psyop.
Don't let my wife read that email. She will certainly put me in the front of the line for the interview.
Got it. So BJJ lowered LP(a) 40% on PCSK9 inhibitors. Very interesting. Now 131. Inflammation markers are great. Calcium score 35, LDL 59, triglyceride over HDL is 0.7. Those are some really, really good numbers, BJJ. Do you believe adding niacin can still be justified for me as I have no signs of inflammation? I don't think it's critical. I think, one of the things that we know niacin, we have known from day one. So just to clarify for other folks, a question has come up in a totally different space. It has to do with LP(a). If you haven't heard of LP(a), go back and we've got several videos on it, and go back and look up Bob Harper. Bob Harper was the physical trainer on The Biggest Loser, and the epitome of good health until he collapsed on the floor one Sunday morning doing cross-training exercises in his personal area with a heart attack. He did then state Well, in less than a week. Yep, it's LP(a). I got that from my mom. LP(a) is genetic, as Bob Harper mentioned. It's a genetic version of LDL. It does increase risk for heart attack and stroke. We've got many, many patients that have LP(a) problems. There's been a lot of debate, just like debates in other areas. The big debate in LP(a) treatment has been whether or not to use niacin. I've got several videos which go into depth on that whole debate. The short story was there were a couple of trials using niacin that didn't work. One of them didn't take into account they were putting. Oh, James, I'm having a senior moment. I'm blanking on the chemical that they were putting in the niacin. There was a chemical that they were putting in the niacin to decrease the flush reaction. That chemical appeared to decrease the positive impact of the LP(a) as well. Anyway, a couple of other points about that debate. Some of that's going to be going away over the next few years. There are a whole new class of drugs similar to the messenger RNA drugs. There's a genetically driven, what's called antisense class of drugs, very similar in genetic mechanisms to the messenger RNA components, except sort of the mirror image. Those antisense drugs are not quite ready for prime time. They're not ready for prescription yet, but they are coming out with 80 and 90% decrease in LP(a) values. So lots of promise with these drugs. As we all know, when drugs like that come out, they tend to cost a lot. So back to BJJ's comment, do I think that he needs to take niacin in addition to what he's taking? A couple of questions I would have. Well, I think you answered that. A 40% lowering on the PCS using the PCSK9s and a decrease in your inflammation panel. I think there's very little evidence if you've got zero inflammation going on that you're actually having a problem at your current lower level of LP(a). That's a great clinical question. I really appreciate your bringing it up. Gives me an opportunity to make that information available out there. Thanks, BJJ. So to the next question, burning questions. Burning questions, I think you might have changed your name. I think I recognize that image. Let us know if you have. I believe Fauci has friends in ModeRNA or stock. I think he has ignored outpatient therapy to boost ModeRNA stock. I would need nose plugs when getting a ModeRNA shot. Interesting comment. I don't have a response to that. I will tell you, gosh, speaking of responses and comments, we're getting I don't think we're going to be able to keep up with the comments guys. Today, they're really coming in fast and furious. Mark Spencer, go ahead, James.
I can summarize some of them. I've gone through and read them. There are great questions, and thank you for everyone being so engaged in this. I think a lot of them, and summarize some of them for you in groups, a lot of concern about what we're seeing in the news with the allergic reactions and why you think there may be increased allergic reactions around the Pfizer and the safety issues with those allergic reactions, what causes it and what issues. So I'll try to summarize some of these for you to speed it along if you want.
I hate to tell you, I don't think I'm ready to answer questions. I've seen some of that stuff. I think if I tried to give you my opinion right now, it would be not well enough founded and maybe cause more confusion than help. So I'm gonna defer on comments about the allergic reactions to the Pfizer vaccine.
Lots of other comments.
I will say this one thing. I have not counted the Pfizer vaccine out at all, anywhere near. I'll just say that.
There's one comment on here of someone that's actually in the trial who's taken the Pfizer vaccine. As I think they're saying they're in the trial and that they have good response. They're very positive about it. But if it's in a trial, I'm not sure, you may not have gotten the vaccine. So you may have gotten the placebo. So I'm not sure. I'd have to dig into that to make sure that whatever that's representing, but it's good that they're positive about it. A lot of comments forward about concern of whether you be forced on a plane, not to ride a plane, not to go in a restaurant, whether you've had it, whether you've not. And if Gilbert wants to skip over those, I think those all fall under the same category of speculation. We don't know. Every state in the United States is different, and every country is different in the world. And whether they'll be forced and whether it's even reasonable, it's not a lot different than masks. I'm not a big advocate for masks because you and I understand that in certain contexts, the mask, as much as they're beating us down on it, is not going to make a difference. But in other contexts, I can see two things: one, where they're good, and two, where it at least helps some people in some contexts feel good. And just as a good citizen, I go, it's not that inconvenient for me at times to put the mask on. But I don't think there's any way to tell to you whether or not I'll fly, not fly, eat at certain restaurants. I think we're 6 months away from seeing how that shakes out in the general population.
So again, I think we've started to talk about, I've got a lot of questions about whether you'll be allowed to fly. I just want to make one comment. I made it last week, and I think it's, again, worth repeating. A lot of people have asked some well-informed folks, are they flying? I heard a presentation by one of the infectious disease specialists that consulted with the airline groups many times in the past. And his response was no. He was not comfortable flying yet. His reasoning had to do with the engineering of the HVAC system on airplanes. What they do is you'll notice the air comes out from up above the human bodies, and then it pushes down, and the exhaust comes under the feet. What typically happens in the plume, the exhale plume from a human body, is that it goes up, which, it's heated relative to the rest of the air, so that warm air rises. So instead of creating a laminar flow, this top-down creates turbulence until unless that part were fixed. That ID and epi specialist is clearly not interested in jumping on a lot of planes. I'll leave that comment. I know that any of these comments in this space can create debate. Will I need a vaccine to get on a plane, passport? I don't see that happening again over the next few months. I think the question is, can they get the vaccine out to as many people as will want it? Fauci is long known to push vaccines in the past. Just browse YouTube. Well, I need to show my vaccine card to get into a theater, pub, restaurant. Will I be forced to, by not let you go to store? We'll be forced with a vaccine card. Yes, I'm very aware of this. There's a lot of comments out there about, again, getting to, for those who have studied the Christian Bible, the Revelations talks about Mark of the Beast. And a lot of people are beginning, as James said, a lot of religious groups, and a lot of, we've seen comments in here, I'm not religious, I'm just nervous about what's going to happen to my personal rights. Again, I don't really, we can make some comments about that. I don't see that happening in the short-term future here in the U.S. Well, I'm not going to read that one, Andy. C. Lear, other countries may require a vaccine before allowing you in. Yeah, that's very true. I would not be surprised if the military begins to require vaccine. Again, let's have this conversation 6 months from now. I think it very well might change. BK, can't say the C word on big tech YouTube. Not sure what C word you're talking about. Big pharma, government overreach by a little focus on the vaccine. It's all about dollars. Skunk Ape, does statin therapy influence steroid hormone synthesis or low T? There's been some stuff out there. I'm not that familiar with the evidence one way or another. The evidence I have seen, though, has clearly not been convincing. I am not worried about low T or other hormones regarding statins. And the reason that comes up is that cholesterol is a major building block for a lot of these hormones. I'm just going to leave that comment at that, unless, James, you wanted to make any comments.
Okay, no knowledge of it.
Mr. Bolowitz, why do people have this stupid notion that the vaccine for COVID-19 shall be made mandatory for everybody to take? I have a similar question. I understand that as well, Skunk Ape. You're not the only man that doesn't want to have a limp noodle. John Tocho, smash the like button and think about joining Patreon. Thank you again, John. There's, again, a lot of participation, a lot of interest today. If you guys, one thing you may not know, and I will routinely invite people to do that. Even if you don't like the content, smash the don't like button. And here's why. The algorithm reads that and they say, you know what? People are paying attention. There's got to be something here that people may want to know about. So thank you again, John. Ronan Gabriel, why do they add immortal cell lines in vaccines? Gosh, that is a very interesting question. And I don't remember the name of the movie, the name of the book. There was an immortal cell line, Henrietta Lane, HeLa, H-E-L-A. It was used for the laboratory diagnosis of, I believe it was cervical cancer, pap smears. The folks at Harvard, there's a great movie about that. The folks at Harvard that developed that cell line and sold it did not ask permission of the patient that they got that from. This was decades ago. And reparations, unless I'm mistaken, I haven't seen the movie. Unless I'm mistaken, reparations have been made. For Oak Far, 90%, 95% is the effectiveness of the protections of the vaccine. Are these numbers relative or absolute risk? Oh, that's a great question, Farouk. And here's the thing. I've asked that same question so many times. You get into, that becomes very, very significant. And you get into this in so many places. But here's the answer I would give you so far. I haven't seen the data made available for me to answer that yet. Bart Robinson, like button has been smashed. Thank you very much, Bart, and thank you for the reminder to the others. World Traveler, you want to go to school and travel, you have to get a vaccine. Your choice. Bill H., what's the difference on an RNA vaccine? Are there any separate risks, or are RNA vaccines doing something traditional vaccines or not? Well, most viruses use RNA as opposed to DNA. And there are a lot of RNA vaccines out there. I don't know, I mean, I know that that makes a difference in terms of the mechanism of constructing the vaccine, but I'm not aware of significant separate risks. How about you?
That question has come up. I know Dr. Vigorous and I discussed it some with the AstraZeneca as using a weakened virus. So does that increase the risk? If you are at risk, would you rather have a messenger RNA? Is that less risky if, say, you're a high-risk patient versus a weakened? I think that's the question they're getting at.
So that is, actually, that's a great question. I haven't seen a whole lot of information out there. And while we're going down that path, I'll just maybe add another wrinkle to the sci-fi fear component. You know, a lot of people would say, well, look, one of these vaccines, the Oxford vaccine, was made using a, quote, harmless vaccine, and B, putting the DNA from a killer virus into that quote, harmless vaccine. What if you end up with some sort of mutant that's that we don't understand and kills a lot of folks? And are we getting too deep into messing with nature? I think a lot of people actually do have that concern.
Well, there's a movie about it. I mean, that's the Will Smith movie. That's exactly the plot line of the Will Smith movie that killed off most of the population of the world. And so maybe we're so influenced by Hollywood because we know Hollywood so represents the world in science and medicine so well that's playing in, I think, a lot more people's heads than we recognize.
So here's one thing: don't misinterpret the smiles as derision or making fun of any of the comments.
I'm speaking for the world when I see those questions. Yeah, yeah, those are real questions. Get them all the time.
You do.
Hearing good questions. I laugh because there's 20 people typing that as we speak. I'm not laughing at their questions. I'm going, yeah, everyone wants to know that question.
And I didn't see that Will Smith movie, so as you know, you didn't have to see that movie for that to come up. Right. Again, I'm going to go back to the original analogy, and a lot of people aren't going to like it, but right now it's the reality. It's sort of like a car or an airplane. Things can go wrong. I haven't heard anybody put any kind of guarantee on a vaccine.
I think we have, was it 19 with Pfizer, 19 significant illnesses that came. I think that was the number. It was 19 and 5, if I recall, out of 15,000. So, I mean, there is a reality that some people do respond negatively to vaccines, just the general statement. That's why they have the fund to, to pay people who are harmed by vaccines. So I think acknowledging that's a risk, just like there's a risk of not getting the vaccine. Both of them have risks. You choose which. I think it's the liberty of choosing which risk I want to fight. Which battle do I want to fight?
I will tell you this. I do plan to take a vaccine when it is available. And I know a lot of people, it sounds like I'm probably in the minority when you hear the comments on this show. I can tell you from the demand comments and evidence I've seen out there, I'm not in the minority. There's going to be a lot of people lining up for the vaccine. I will also say, I'm not going to be asking Tony Fauci or any pharma group. I'm not going to be depending on any of them to bail me out if I have a problem with the vaccine. It's buyer beware. It's just like seeing a doctor today. So, James, you mentioned Dr. Vigorous. Do you want to take a minute or two and describe some of the plans that we have for the YouTube live sessions, bringing on, for example, some of the guys from Harvard, bringing on Dr. Vigorous, bringing on some of the other folks?
Yeah, Dr. Vigorous, David Vigorous, medical school at Vanderbilt. We've talked about him some. Also a great infectious disease expert. He'll be coming on a little bit later as we get further down the road with vaccinations and maybe look at what is happening now that's occurring. And he'll be speaking to a number of questions, concerns about that. So he's an expert in that. I think Dr. Stefanos Kalis will be coming on from corporate health perspectives. We want to bring him on to discuss how do you deal with this at work? What a reality, some of these questions that come up that we think will occur. Some employers will say, if you're going to come back into this work setting, you have to. We already do that in healthcare with Hep B and other tests, the flu shot, so forth. So how do you deal with that as an employer? What happens when you have an employee that doesn't want it? So we got some insight. Dr. Kalis runs the environmental health program for Harvard. So those are some of the ones I know we're looking and planning into the future specific to this topic because it's a hot topic of COVID. I even asked, Ford and I have a mutual friend now who recently flew on an airplane and caught COVID-19. And I was intending on bringing him on for a little bit to interview him live. What's it like while you're fighting it? Because he is sick with it. He is symptomatic. But he had to go to the doctor. So we couldn't bring him on today because he thought his good health was more important than the intrigue that we have to interview a live patient. So it's so selfish of him. And so he's doing well. So there's some things in the future. We'll also take forward, I think you said this, if someone wants to put some comments in, what would they like us to cover, both with this topic and others that could be entire topics? As we expand this, we're looking to maybe doing 2 times a week. So if you have some topics and you want to put those topics for broader discussion and even recommend some people we may interview and discuss this with, it's wide open. We'd love to have your feedback and interest.
And I would say, I appreciate the comments during the live session. YouTube, I don't understand why YouTube does this, but they don't make these comments. They don't carry the live comments often completely over to the permanent video when they do the permanent YouTube live upload. I haven't seen whether Facebook does that or not. So if you have a request that James mentioned, and we didn't deal with it during the show, go back and make sure that the request got in so we can see it later. I did want to mention this, this comment from BK. In a recent Boris Johnson press conference, health minister said, just because you get the jab, and that's what they call it in the UK, the jab, that doesn't mean you cannot spread it. Have to stop social, and so therefore can stop social distancing and wearing masks. Huh? Thoughts? James mentioned that he's not as much of a mask fan as I am. I'll make one comment about that space. I think some of the evidence that's coming out is not so much the filtration ability of a mask. It's more the Brownian motion components of masks. And I would agree. I think I'm a little bit less questioning of the mask requests than James and some other folks. Now, but what does this mean? If once you get the jab, you shouldn't be able to transmit it, right? Well, that's not entirely clear yet. And in fact, there's maybe some evidence that that's not the case. So you got to remember how the biology works. A major portion of the spread is happening before you even, not in this virus, but almost every virus we know. A lot of the spread, and in fact, in some viruses, the vast majority of the spread happens before you develop any symptoms whatsoever. In other words, before your body has mounted a significant immune response. So, yeah, I don't think it's at all appropriate to make an assumption that once we get a vaccine, we can no longer get infected or that we can no longer transmit it. Let's put that concept on hold until more evidence is out there. John Tocho, I'm taking my vitamin D regardless. I am too, John. Thank you. And have been for years, and with zinc as well, as have I. But we'll be getting the vaccine. The docs, et cetera, are going first. So if they take it, I will take it.
It's a great point about the docs taking it. I think the funniest meme I've seen recently was the one that says, and when it comes to the vaccine, let's give it to the politicians first. And if they don't fall over dead, we'll take it. If they do fall over dead, then we'll be glad we had the vaccine.
You know, I'm sure you've seen several of the pictures. There are a lot of prominent politicians volunteering. Mm. So you may get your wish, James. Truth seeker, build your immune system by staying away from a doctor. No argument with that. And do all natural organic nutrition like we did before Big Pharma and for thousands of years. No argument with a lot of the criticisms of Big Pharma either. Just not going to get. Chuck K, good morning, Doc. Great topic. How long after rolling out these vaccines before we see unforeseen complications? Your guess is as good as mine, Chuck. And I think the bigger guess is, what will the unforeseen complications be? Angel Luis Fuentes, businessinsider.com, Moderna Chief Medical Officer vaccines interview. Well, thanks for the citation. I think maybe James, did you ask for that citation?
Yes, he was. And I've responded to him already.
Okay.
Where we reviewed, but the link wasn't hot to look at, so we'll look at it after line response.
Truth seeker, we have a blood membrane barrier for a reason, but doctors like to poke through it all the time. Angel, YouTube does not allow to copy link. I'm very much aware of that, and thank you for your patience. We're continuing to get so many comments the thing flipped on us again. Michael Duran Ruiz. Hi, Michael. James has, I think you responded there, didn't you? Mr. Balowitz, I'm from a third world country. Please be honest. Do you think we will achieve herd immunity before the vaccines become readily available for us? I don't. James, any comment from you?
No, Taiwan's the interesting place, right? When you look at Taiwan, it doesn't appear to be impacted, and I wish we could do more social research into why Taiwan is dealing with this so successfully as opposed to other countries.
So back to Angel's comments about ModeRNA. Their chief medical officer says that the vaccine trial results only show that they prevent people from getting sick, not necessarily that recipients won't still be able to transmit the virus. Thank you so much, Angel. And yes, I've heard the same thing. So again, please don't assume that you cannot get infected, because you clearly can. With any vaccine, you can still get infected. The question is, are you going to get sick? John Taylor, will you guys both get a vaccine? I plan to. I think James is going to be wishy-washy about it, or maybe wait.
No, I'm going to watch. If you fall over dead, I'm not getting the vaccine. If you do really well, if you're so much older and I'm in such better health, that if it works for you, sure, I'll do it at that point.
What if I don't fall over dead, but I grow a horn or a third eye?
Well, it depends on where.
Organic natural foods have anti-inflammatory processes. Real nutrition, organic superfoods. Stay healthy. Big pharma synthetic lab make drugs, break down the immune system. Again, I understand. Steve Sapel. Hi, Doc. What's your opinion on the use of ivermectin as a prophylaxis prior to getting the vaccine? Ivermectin has been shown to be very safe and effective. Unless I'm mistaken, Steve, I've looked at that a couple of times. Docs have used that, and I have as well, in terms of treating of helmets, vaccines. I think we've got some freezing going on here. James,
yeah, it's been going on. I apologize.
Yeah. Bottom line is, no, I would not take any of these as a prep to the vaccine. I would not want to manipulate my immune system, do anything that could manipulate my immune system during prior to getting a vaccine, as we talked before about even aspirin. John Tocho, I heard on the news a very detailed story that the airlines have upgraded their air filtration systems, and a study said very unlikely to become infected with COVID. Very interesting, John. I'd love to see that, and thank you for making us aware. Joey TS, the manufacturers have liability immunity. They cannot be sued if their product harms people. This is a big red flag. Where there is risk, there must be choice. Informed consent, free of coercion. Again, I don't know that you're going to get that much argument about that, Joey. I don't think you will. Richardson 75080, if you get the virus now, what meds would you want to take? You're talking to me. Despite some of the problems we've seen with remdesivir, especially problems we've seen with the convalescent serum, and always problems with steroids, I'd be voting for all three of those if I get put into the hospital with this. Angel, so if vaccinated, you can get sick less severely. You still get to transmit to others. There is no herd immunity. I understand. Not going to respond to that. Thank you very much, Angel. There's some very good points. I think what we're going to end up seeing is a greatly decreased. I think that maybe some of the confusion that we have here is the assumption that you can't get herd immunity if there's any transmission. I think the question is it possible for a vaccinated person or someone who's had it before just to get infected again, to spread it again? I think that possibility exists. Is that person going to be as likely to spread it as someone who's never had exposure through vaccine or virus? I don't think that's the case at all. So I think there's going to be significant impact on spread on a population or herd basis. Joey T, the manufacturers, well, Joey, I think you already said that. BK, COVID, C word. Okay, thanks. Got it. Yeah, you're right. You mentioned COVID, and I've actually had a couple of videos taken down. Truth seeker. Fauci is not even a doctor. The WHO is funded through Bill Gates. Gates is not a doctor either. Wake up, folks. We're being pushed into a global reset. Here's one of those New World Order comments. Another worries the manufacturers cannot be sued. Well, I think we said that a couple of times. Over 4 with a whole lot of zeros paid out in settlements. But these are paid by the VIC people, the people themselves. Adam Lopez, Israeli press reported the Pfizer advised FDA as it sees approval. 2 people have died in their trials. Have you heard of this? I haven't heard of anybody dying in trials. Have you, James?
I have, but I think they have to report in those clinical trials. If you get run over by a bus, you have to report that someone in your trial died. I think it's disputed whether the cause was the vaccine. In fact, I think I remember one of them was certainly confirmed as a placebo. So, okay. But you do have to report when you do a clinical trial. You have to report, irrespective of what the cause was, of any variation in their health during that time. So, I'm not discounting that it's something to be concerned about, but I have heard that.
So, James, you'd be interested in this. You got an interest in those lost civilizations. You want to read that and comment?
I'm familiar with the guidestones. It was, they're engraved like tombstones that was put up a few years ago by a group, and so I'm familiar with it, and I'll just leave it at that. There's certainly, one thing you have to acknowledge for it. There's an education here. There are a lot of people who are raising these similar concerns as to where in the past, one person out of 1,000 may raise a concern. We're getting 30%.
A lot. Yeah.
Raising a lot of these concerns about why. And I'll give you an example. Why? Here's why. Here's the common sense why. Let me defend it a little bit. Because there is just so lack of common sense. And you fought the battle on one of the COVID task force that you and I were on, where the science side would say, we're going to follow the science. And then they would go into a 30-minute rant that had nothing to do with science and could totally ignore the science in that. And we know that there are politicians and do-gooders in these processes that are saying, well, let's just not do something. So let's do something. And a perfect example was the airplane. So they're saying, well, the airlines are saying, well, you can fly now. It's safe because we've redone the ventilation system. So we do know that was causing a lot of it. But I'm sitting 2 feet away from another person who may have it. So yes, the ventilation system is a problem, but common sense says, well, why am I social distancing 6 feet if I can capture it from the person that not only is 2 feet away from me, but I got to get a lap dance from when they have to go to the bathroom in the back of the airplane. And just common sense people say, well, since there's so many disconnected, contradictory advices that everyone would acknowledge for your, then it's natural that people would default to some version of conspiracy because there's so much of that. And I often say there's conspiracy and then there's just stupidity. I'd never underestimate our human capacity for stupidity versus conspiracy, when simplest explanation can be not conspiracy.
Yeah. So while you were talking, James, I went through the rest of the comments. There's a lot of continued comments about by Joey TS and Truth Seeker. We're very familiar. You've got a lot of concerns. I don't think we're going to be able to handle them all today. I don't think we're going to be able to handle them, period. We did have a couple that I think we can speak to. One of them is what's a recombinant vaccine? Recombinant basically means genetically engineered, and that scares people. the bottom line is whether we like to, well, I know that I'm going to get some hate. You shouldn't go on YouTube if you're afraid to get haters. In my mind, we've been genetically engineering animals and crop products for many, many generations. We just did it through crossbreeding in the past, and now we're actually doing it through microscopic biochemical means and genetic. Go ahead.
There's no denying that some of the best cancer treatments, life-saving cancer treatments, that if I get cancer, certain forms of cancer, that's exactly the treatments that I'm going to beg for, that are working effective with, we don't have to worry about side effects because they saved your life. So they prolonged your life. So there's some very positive science advances in genetic modifications.
Another question, Richardson 75080, which again, I think we may be able to respond to. If you had the virus now, would you take a fever reducer or just let the fever run its course if not too high? I tend to let fevers run their course if it's not too high. The major concern I have about if you have the virus now is not so much worrying about your fever. It's making sure that you're doing a pulse oximetry, checking your pulse ox on a regular basis. The problem, the problem with this virus and the problem with getting into a full-blown COVID-19 reaction to it is loss of your ability to transfer oxygen. And it happens, it's fairly deceptive. It happens and people don't even know it. So we had several different videos on talking specifically about this. As you see, it's a very simple process. I don't see other comments that I think we're equipped to respond to. James, do you?
Other than that we're a good team like Johnny Carson and Ed McMahon just came up from Skunk Ape. But again, I think we're a lot of the party.
Which one's Johnny Carson? Well, maybe, and which one's Laurel and Hart?
You have more hair. So.
Thank you, Skunk Ape, for the, I'll take it as a compliment. I'm not sure whether James will or not. And I also take it as a compliment that many people have tuned in. A lot of people are very interested in this. And thank you for your interest. James, you have anything before we go?
No, I don't. Thank everyone again for putting up with my part of this, but it's a lot of fun, exciting. And thank you, Ford, for being reasonable. Someone made that point. You're very reasonable, very open, and well knowledged. And we look forward to hearing from the hearers of future episodes of what we can do.
Thank you much. And we look forward to future episodes as well. As we said, it's just been mostly a one-man band. We've had people on. It helps a lot when you have a conversation rather than just one person pitching. We've had a lot of folks. You've come on originally, James, as a patient and shared a lot of your own patient experiences. I appreciate that. Patients speaking to other patients is a big, big deal. And now I'm very excited about your recommendations to get some of our some world-class medical scientists on board to talk about some of these topics.
I'm also remember I'm on the Libre for 2 weeks as you're working through your eat to the glucometer trial, and I'm going to talk about that experience in a couple of weeks, which is exciting. It's a lot of fun going through it as a guinea pig.
I am so tempted to tell that story, but I will hold it till later. Thank you much.
Right. God bless.
Bye-bye.